seems almost overnight how mobile technology has become the center of everything that we do. So many things that you do now on your mobile device, it truly is a Swiss Army knife. And if you use it well, it's incredibly empowering. There's a dark side to that too. People can't put them down as well, and we could talk more about that. But boy, there's a lot of opportunity for mobile technology. And we're going to explore that now for the next hour, especially as it relates to engaging patients and the pros and cons. So we have a really interesting mix of panelists, and I'm going to ask them to each introduce themselves and spend about 5 minutes telling you about their day jobs, what they do, and how it relates to the topic on the panel. So I'll start right here on my immediate left.
So good morning, everyone. My name is Bob Zemke. I'm the Director for Healthcare Solutions at Extreme Networks. And my background was on the hospital IT operations side, actually making everything work from the applications to connected devices. And today in my role at Extreme, I am the global liaison to the medical device community, industry regulators, and hospital organizations, and trying to kind of handle the capacity of interconnecting all these devices on what now is essentially a single data network. So it makes things very interesting. If you take a look at your house today and how many things connect onto the internet, and healthcare takes it just to new levels. So it's an exciting industry to be at, and always full of change.
Good morning, everyone. My name is Brian Richard. I'm the CIO at Sonicare in Wallingford, Connecticut. We are the leading providers of senior services and senior care in the state of Connecticut. We have skilled nursing facilities, we have a hospital, we have a psych unit, we also have a home health and hospice division, and we also have a lot of residential communities that we're building as quickly as we physically can. They entail independent living, assisted living, memory care, dementia care. So we run the gamut on a whole bunch of different services that we provide. And really our goal is that once seniors decide that they want to move out of their current or existing apartment or home, they will come to Sonicare and live in one of our apartments or cottages, villas, and continue throughout our continuum for the remainder of their journey.
Good morning, everyone. My name is Matt Fisher. I'm the chair of the Health Law Group at Myrick O'Connell. I'm a lawyer. I focus on healthcare regulations and transactional work. So I do, from the regulatory perspective, I do a lot with HIPAA, privacy and security, fraud and abuse, which are pretty much, from my perspective, the hallmark regulations that'll impact kind of anything that's going on in healthcare, whether you're talking between providers, with the health IT industry, or kind of anyone else on the outside that traditional view of healthcare and interacting with it. In terms of kind of the patient engagement and the empowerment side, I've also been working with a lot of mobile app developers recently and kind of the general health IT, and figuring out how that can tap into the industry and be able to help the information flow. Because I find oftentimes there's a lot of misunderstandings about the regulations when we're talking about patient empowerment and data, HIPAA in particular. And as I said, a misunderstanding about what it might allow, which is pretty much anything, as opposed to that it's going to be a barrier. It's just a matter of having to frame everything in a different light than you might have initially thought. But generally, I view my role not as preventing ideas, but as guiding them and shaping them so that you can actually get to do what you want to do and not run into trouble with the government.
Excellent. So you now see, I think, a brilliant selection of people with different viewpoints around this topic. We should have a lot of fun for the next hour. I meant to mention, as far as rules of the game, there'll be plenty of time for audience participation. So again, if you have questions of me or these gentlemen, write them down, think about them, and we'll have plenty of time for Q&A, most likely anywhere from 20 to 30 minutes. So. In the meantime, I'm going to start by throwing out a few questions to these gentlemen, and then we'll see if we can get maybe some fireworks going on the panel. Now, what do you think? So I'm going to start by a very general question for everyone. I want everyone to think about this. We're in a really interesting time. The topic I'm going to share, because it really is about mobile and empowerment in a perhaps a slightly different way, is virtual video visits. And I'm sure all of you are following this. It's a pretty interesting landscape. For instance, Blue Cross of Mass now pays for virtual video visits for its fully insured through the services of American Well. That means American Well, which is a Boston-based company doing this work, has a network of physicians which now is big enough that those individuals can sign in and effectively be on call at any point in time and sit in front of a computer and wait for you, the insured member, to have a problem that needs a virtual video visit. So they have a full coverage of folks that are available, and they offer this service now to employers and plans, and of course it's growing quite fast. Blue Cross, again, will pay for that as a benefit to you. They're also, parenthetically, as a fully insured, because Partners is fully insured, we could participate in the same program. We have to pay a very hefty upfront premium to do so, which is another interesting barrier in its own right. Now, as a doctor in a network that provides patient services, I'm thinking, do I really want my patients that are having a problem in the middle of the night to be going through the American Well Network? Why can't we offer that similar service? So there's that, and again, Blue Cross will pay us to do that. We had to negotiate something a little bit different with them because we have the capability in our partners hospitals of doing this. Most people are just signing up to be part of that American Well Network that I mentioned. And I'm going through a fair amount of detail because I want to set up the question. Also, you may be aware, but you can get a virtual video visit now through Walgreens, through CVS, and so you can get one directly from Blue Cross, you can get one from Walgreens, you can get one from CVS. If your doctor cares to offer it, you can get one from some of your doctors. The volume is not high yet. The volume is probably about 1% of any population offered the service, but it's becoming a stay-in-business application for everyone. So my question to you, all three of you, in your own perspectives, one technologist, one from a senior organization, and one with a legal mind, is that a good thing? Is that chaos a good thing? How will it sort out? What are some of the perspectives you bring to that? And how could we do it better? Go right down the line.
All right. Could speak on this one for an hour. You know, I think it's inevitable that we're moving in this direction, and a lot of it's consumer driven. The expectations of how we interact with different organizations as a consumer. Look at banking. I don't want to go into a bank unless I absolutely have to now. It's reached that point where online banking and a mobile app is preferred. With young children, I really don't want to go into that pediatrician's office if there's not some initial triage going on ahead of time before I'm taking off of work, I'm taking them out of school, I'm taking them into the sick room where they could very well get more, contract more things in that short stay. So I do think there is an expectation of consumers that we're going to embrace the technologies that they're using in their everyday lives and start to apply it into the healthcare practice. And that will be our struggle. Is I look at it from a hospital's IT organization of how are we going to extend support and care and operations beyond the four walls of the hospital. We're going to be shifting our support models, and that's everything from the CIO down to your network engineers in terms of how this technology is going to be leveraged. How are we going to support it 24/7? What do you do when there's those intermittent problems of service delivery? And so very much a service industry is kind of growing in expectation of how we're going to provide health IT.
I would agree with all of that, and in addition to that, how to secure it all. You know, that's another main factor. We're doing this now in our residential communities where we basically have, in lieu of, if someone needs some help, so if they have, we have wander management and due to some of the patients that we serve or the residents that we serve, and we also have the call parade system. So when a patient or a resident is in trouble, we do have people that are on site that can quickly utilize telehealth basically and see if we can quickly assess based with the doc and with the patient and who's ever helping the patient or resident If we can assist, and if that patient can go to our smaller hospital that we have on site, we don't have a triage center or anything like that. It's a smaller hospital. Or do we need to send that patient out to a larger medical center because the symptoms have gotten to that point? So we're using that internally now. Where we could really take it to the next level is through our home health and hospice business. And obviously it's available now, but where we run into the issue is with reimbursement. So if we make a personal visit out there, we get reimbursed better than if we do a telehealth visit. Now that doesn't make that's backwards in the sense that we're driving more, we're having our nurses drive more, we're accumulating costs. They're not as efficient as they possibly could be if they see more patients through telehealth. So to me, it's going to be a challenge not only on the IT side, which I'm very in tune with, but it's also going to be a challenge on the reimbursement side, and really because this is the way of the future. It's inevitable, it's coming, but there's got to be some serious discussions as to how we're going to be reimbursed for this, because as everyone knows, the hospital margins are so thin as we speak now.
And I think that reimbursement piece is a really good one, because that's part of what I was going to, where my mind was going, which is, you have, on the private side, if you're talking about like with Blue Cross, as Joe was saying, some of that you can maybe drive by contract, because you can build into when the payers and the providers are negotiating, maybe you can build in to be able to have some reimbursement for it. And also you're starting to get Medicare going in that direction. It's, they're starting, within the next gen ACO model, I believe, you're starting to be able to utilize these newer tools, because the whole, in my mind, part of it is, as you're shifting from a fee-for-service world into a value-based world, you need to figure out new ways to be able to deliver care, because, as Brian was saying, telehealth, yet not right for every single circumstance, but where it is where it could be an appropriate use of care, you're going to be able to save money, and it's an alternative means of delivering the care as opposed to having to require that face-to-face visit. And I think that's part of value-based care. If you're, because also when I think value-based, I think risk or capitated payments, and that means the provider is trying to figure out how best to manage that money. And once you kind of get that little bit of freedom where you're not tied to, okay, I need to keep seeing these types of visits to keep making money, but how do I best manage the money I've already received? Then I think that's going to drive it. But then, the other side to it, which is probably the more nitty-gritty side of it, or legal side of it, is licensure restrictions or practice restrictions, prescribing restrictions. I think right now you've got 50 states, you've got pretty much 50 different rules. I think as the use of telehealth or telemedicine keeps increasing and keeps getting driven, because I agree on the comment that it is going to be very much consumer driven, because right now in every other industry we have all these tools and we can use them. The regulations are going to be forced to catch up, because people expect to use it, and hopefully that can result in those people who are interested in it being also to influence where the regulations go, instead of having uninformed viewpoints or uninformed regulations put out that end up restricting or causing problems.
Yeah, and again, if you all have thoughts on that when we come to audience participation, please bring it up again, because I think it's a fascinating area right now. It's very chaotic, and I'm looking for someone who has the bright light of how do we resolve it and not make it chaotic. I will say, as we leave that topic, and this is what 20 years of experience does, you see themes recycle in that period of time. And the theme I'm thinking about is how 20 years ago people were very excited about a new thing called disease management. And providers didn't care much about it, and so insurers made a whole industry to work around us to do it, and it kind of failed. This reminds me a little bit of that. Well, if your doctor is going to sit on his or her hands and not watch for virtual video visits, Blue Cross will be happy to offer them to their insured on their behalf, because they want their members to get it. It's a consumer-focused approach. So I'm troubled by it. I want to make sure that that it works out in the right way, and maybe we can come back to that. I'm going to switch gears now and go really in the other direction completely and talk about mobile-facing simple apps, and start by just looking for a little bit of audience hand show. How many people here use any kind of mobile application to interact with their healthcare system? pretty good, that's great, good. And I suspect it's some sort of patient portal type app, basically, which of course Partners Patient Gateway is a mobile interface, so we qualify. I do think that when we talk about empowering, that's the other part of the title of this panel, I'm going to go out on a limb and say that our patient portals, and not just ours at Partners, but generally how we do this, they're not terribly empowering, I would argue. So, and of course, we're pushing them now because for meaningful use reasons and for other reasons, we want people to be on these. So we're really pushing hard to get people to sign up. I would say though that still we haven't reached anywhere near the potential of using these things to get our patients' attention. And I want to ask panelists, again, each one of them has a different perspective. What do you think about why patient portals haven't taken off, and what would you recommend we do to make it better?
From a consumer standpoint, I mean, the patient portal I use for myself and my family is obviously just an extension of the EMR platform of the hospital. It's not been designed based on every other app I use in terms of ease of use. I also have noticed disconnects where even though theoretically my primary caregiver is connected into the portal system, I've had duplicate messages from both saying it's time for inoculations, where I just got one as part of an annual physical, and now the local hospital is telling me through the portal that I'm due for tetanus and TB and a few others. So I think we're really in our infancy of what a portal should be, and it's very crude right now. And until we get, like you said before, better developments from a user experience or user interface standpoint, we're not going to see much mainstream adoption. I think it's going to be a few people logging in on occasion, but not leveraging it much.
I don't have too much more to add to that. I agree, and you know, it's almost instead of, you know, when you're walking out of the office you have paper, now you can view it online. So there's not much difference there. I would take it from the senior perspective, where it's a little different, where it's not so much my patients and residents that are getting on. Some are you know, logging into the portal, but it's more the families. I think that's where it helps them. So in particular, the families that are not local, the ones that want to keep up on mom and dad's condition, they can log into this portal. I think that's where the key comes in for those loved ones that have that are distance challenged.
Yeah, no, I pretty much agree. It's, you know, from the personal perspective of using the patient portal app from my provider, you know, it's actually, I've found it so far, because I actually just switched to a new provider where I could download the app, because my previous provider, I think I logged into the patient portal and there was absolutely no information in it. Whereas with my new provider, as soon as I registered, it started to get populated, which was very nice. And now on the app, I can get, you know, I think I got the test results from my blood draw with, I think, the afternoon after I went into the lab to get my blood drawn. So the stuff pushes through pretty quickly, which I think is interesting. But I agree, it's how does it then connect to everything? Because it's basically an app in isolation. You know, so you know, maybe part of it is, you know, how is that portal maybe morph into like a personal health record type app, or you know, how do you get out of the silos? You know, that's certainly a theme that I keep hearing repeated in following other things, which is we have to break down the silos. We have to have everything be, you know, free flowing across areas.
We'll do that. I guess yeah, my mic's better. We give the AV people a hand for changing the batteries in mid-flight there, huh? Yeah, so we'll let you pay your bill. That's one of the first things we implement. I guess that tells you a little bit about our perspective, sadly. Well, again, I think this is a rich topic, and we're not going to do it justice in 5 minutes, but it could be something we open up later. I wonder if anyone, so let me ask another show of hands. How many people here think that open scheduling would be a good idea through a mobile app? Almost everyone, right? There's a few people who think it would not. Maybe your doctors, I don't know, because doctors are terribly afraid of that, and I don't quite understand why. But it's, again, my CIO, Jim Noga, I don't think he'd mind if I told this story, recently called out my department, and so that's why I feel like I can tell the story. I'm a dermatologist and my practice is at MGH. And he said he called to schedule or reschedule, I think, an appointment. And of course, you get voicemail right away, or you get on hold right away. And he's on hold, he said, by the time, so I waited on hold for 10 minutes. I booked a flight, I booked a room, and I booked a car. And then at the end of the 10 minutes, it said, if you've been on the hold longer than 10 minutes, please hang up and call back. So we have a long ways to go in customer friendliness, and mobile is that's so much the heart of what mobile does, is it puts it in the palm of your hand. I was in DC yesterday to talk to another healthcare delivery system, and I checked out of my hotel. This is going to sound sort of silly, but I checked out of my hotel using my Marriott app. And again, why can't we do stuff like that, right? Other industries have embraced it and done it. I don't fully understand it. So again, maybe someone who didn't raise their hand and thinks open scheduling would be a bad idea could comment during the comment time, because I think we've got to start doing more stuff like that. So we've gone from sort of something very clinical, virtual video visits, all the way to something as mundane as open scheduling, or being able to use your portal in a way that suits you rather than as a regurgitation of what I write in the chart. Pretty interesting stuff. Pretty interesting stuff. So I have one individual question for each panelist, and then I'm going to open it up, and we'll see how we do for the remainder of the time. Brian, so Brian works at a senior care organization, and the common perception, Brian, is that seniors are technophobic and that they don't want to use or they can't use technology. I'm curious what you found in that regard. Is that true? And do you have stats? What are we missing, or is that an accurate thing, and we need to do a better job of designing for them?
I think the answer is yes, no, and it changes by the day. You know, I've got some seniors, and this even plays into my own family. I've got, you know, my parents are 79 and 80 years old. My mother wants absolutely nothing to do with a mobile device by any means. My father, on the other hand, wants everything. Doesn't know how to use any of it, but wants every whiz-bang gadget that's new to the market. You know, I equate it back to the old Seinfeld episode years ago when Jerry gave his father some type of device, and all his father kept saying, "I love this tip calculator." You know, that's what my father basically has. He's got tip calculators. But you know, seriously, I mean, it really depends on the condition of the patient. Obviously, if a patient has, you know, serious dementia, or they're going to be, you know, obviously less likely to use mobile devices. But a lot of the residents that we have are starting to embrace technology, and it's due mostly to their families. It's their children that are in their 40s and 50s, and subsequently even grandchildren. And again, this goes back to my own family now, where, you know, my father calls with questions all the time, and I just defer him to my children, because I try and tell him things and he won't listen. And even he says, I'm on the computer at home, he says, and I'm trying to do this, and this, and I can hear him clicking and clicking and clicking. And Dad, stop clicking, stop clicking, stop clicking. You know, and so I said, okay, you know what? From now on, you're going to talk to my two daughters. They're 14 and 16. They can handle all of his questions regarding the computer, his iPhone, his iPad, which my wife bought him for Christmas, and I'm still swearing at her to this day about that. But overall, the adoption is coming slowly but surely. I think with a lot of the newer technologies, sometimes it happens by chance. And Joe, you mentioned earlier about the wearable devices. We have a lot of our patients and residents throughout our continuum that are just starting to utilize the wearable technologies, and we're working with 3 major vendors, and we're without even knowing it, they're participating in this, in the sense that, you know, they are moving in the technology direction. They know they're obviously wearing this wearable device, but then we're going back and showing them the results of why we're doing this, and we're educating them as we go. So it is a struggle. We've got many different locations. The IT department has been well trained, and we subsequently train a lot of the different directors and the people that are responsible for treating these patients and residents on a daily basis on how to use some of the newer technologies. But you know, the basic question we provide, the infrastructure so that they can get on easily, that their loved ones, when they come into their home or apartment, resident, village, cottage, what have you, they can jump on wireless quickly. And we also provide them with a safe, secure network, you know, through the portal to have access to their loved one's electronic medical record.
Yeah, I do think that the user interface that we use on smartphones and tablets now, the sort of touch and tap, has really made a big difference. We have a relationship with a Boston-based firm called Kvedar that uses Withings sensors, blood pressure, cuff and scale, and an iPad for home telemonitoring for heart failure and other illnesses. And of course, most of our heart failure patients are in that same bracket. And when we first started working with Kvedar, their reasoning was, well, to move a blood pressure reading and a scale reading once a day requires almost no bandwidth. So we're not going to put a big data plan on these iPads. We'll put the minimum data plan. And the patients blew through it in 2 days watching YouTube. It's true. It really, that's true. So, you know, we don't give them enough credit. I think sometimes you put stuff in front of them, and certainly my father-in-law's in his mid-80s, and he's as attached as he can be to his iPad and his iPhone. So I agree it's spotty, but I see a lot of promise. I see a lot of promise. I'm going to turn now to Matt. We have, the legal voice here. Something that I think is, I'm going to go back to the virtual video visits a bit and ask an important question. You hinted at this, Matt, but I want you to talk more about it. And it's the following. So I work at the Mass General. The Mass General Physicians Organization has created a sort of an innovation pot of funds that they set aside to reimburse their clinicians who are providing virtual video visits while we figure out what the marketplace is going to do to reimburse us. And the notion was, and I give the leadership enormous credit, to say we have to figure this out ahead of time. Right? We know it's coming, we believe it's going to be big, we have to figure it out ahead of time. So we're going to set this pot of money aside. We created some codes that mean nothing to anyone but us, but when I do a virtual visit, I can put a code in and something comes into my paycheck. It's a small amount of money. It's not the same as I would get to the point that was raised earlier as a in-person visit, but it is, I think, important to point out that at scale it would make up for that because you can do them faster, and it's enough to recognize that my time is precious. So that seems like a good idea. Wouldn't everyone think that's a good idea and congratulate the MGPO for doing that? The lawyers are not happy with us. And it has to do, and Matt will explain it more fully, I'm sure, but it has to do with the fact that maybe we're offering a service to a patient that that there's a fraud and abuse component to that, or I don't know. Tell us more about that, Matt, and why that's a problem.
Yeah, so at a high level, I guess maybe the first question is, for everyone here, who's aware of, like the Stark Law and the anti-kickback statute? Right, so not as many hands as when Joe was asking questions to raise hands, but those are the two primary fraud and abuse laws. They're coming down from the federal level. So even though to some degree, Stark certainly only applies to Medicare. In the legal community, there's a huge debate as to whether or not it applies to Medicaid. Mass Health here. I think it's clear from recent, from the past couple of years that the government is certainly seeing that or saying it applies to Medicaid. So I just assume for ease of reference, at least for right now, and without getting into extreme detail, that Stark applies to any federal health care program. It's a civil law, so it sets out requirements. Baseline is if there's a financial relationship between a provider and then an entity providing what's called a designated health service, which is pretty much all of Medicare's parts A and B, along with a whole host of other services. There's 13 elements in the regs, and then it refers down to an annual regulation that CMS can update, which is, I think, a couple hundred pages long, listing out different codes. So it's the majority of services. So if there's a financial relationship and there's going to be a referral for DHS, that's basically prohibited unless you fit into an exception. Then there, so there's, I think at this point we're closing in on 26 different exceptions, at least for financial relationships. Then there's, other pieces of regulation that create further exceptions. So it's a very arcane, convoluted law that is designed to trip you up and basically allow the government to say that a relationship is improper. And I hate to say it, but it also gives me full employment, because it's impossible to get through Stark without having legal counsel, and especially counsel that actually knows what healthcare is. Because from my perspective, when I see a problem from a relationship that's been set up,